So, good morning, and good evening, good afternoon, depending on where you're from or where you're listening from. Today's feature is going to be unused coronavirus tests in U.S. labs, and there are a lot of them. Now, there's a lot of different arms and legs to this story. Someone was just asking me, be aware, Doc, that up to half of the tests are false. That's actually the case when you're talking about the antibody test. And it's not all because all of the tests are bad. A lot of it's because we've got such a low prevalence of infection. It has to do with predictive value of a positive. Now, if that sounds geeky, we'll cover that a little bit later. But that is a major, major problem. That's not the problem that we're talking about right now, though. Right now, we're talking about the challenges in getting the tests to market, the different tests, the viremia, the virus test, not the antibody test today. What are some other topics that we're going to be talking about? Not today, but over the next week or two. 6 conditions for ending the lockdown. And it has to do with some things that might be obvious. For example, is there hospital bed capacity, ICU capacity? What about your infection status? Have you been infected before? What type of work you have, et cetera, et cetera. We're now working with a very large U.S. employer. And again, these are the big challenges. All of us want to open up the economy and get back to work. But we don't want to kill a lot of people doing it. So we've got to think about how to get that done. Part of that has to do with, well, who's actually immune to the coronavirus? There's a lot of questions about immunity. If you look at other a lot of people say we know nothing about immunity to the current coronavirus. How long will it last? Is it effective at all? That's not entirely true. We do know a few things about it. For example, if people were routinely getting reinfected, as in anybody and everybody that's had it, were getting reinfected within a matter of weeks, that would have been very obvious, painfully obvious, lethally obvious, but that's not happening. We also know some things about the other coronaviruses. There have been other coronaviruses cause routine things like seasonal cough, cold, sore throat. And we know a little bit about immunity there as well. It's not complete, permanent immunity, but a lot of that immunity is pretty good. So we'll get a little bit deeper into that discussion at some point. Somebody asked me about pregnant women and coronavirus. I have tended to ignore that because we haven't seen a whole lot in that space. We do know this, for example, though, there are some influenza viruses, seasonal flu in the past, that have been lethal for pregnant women, lethal for their unborn babies, very, very dangerous. This one does not appear to have been so, but we're going to get a little bit deeper into that topic when we cover it as well over the next week or so. And then a perennially popular topic, which COVID-19 treatments are working and what do we know about them and how well, and about how well they work. Previous topics that we've covered that are in the can. Unfortunately, most of our videos include the Q&A, and we're just now getting the team geared up to where they slice off that Q&A and just cover a shorter video, 15 to 20 minutes worth of the topic, the program for the day. We need to be doing more of that to provide people that are viewing these later after the live Topics that we've covered are we hitting the peak? And again, deep. It's a lot more complicated than we think. It's not just one peak for the world. It's not just one peak for the US. It's not just one peak for New York or Kentucky. So a lot of detail in that question. ACE receptor blood pressure medications. We've covered that several times. Social distancing, herd immunity, COVID-19, and heart damage. So again, many of these things keep coming back up, and they're critical pieces of information because the ACE receptor blood pressure medicines are some of the best and some of the most popular. So we continue to do a lot of research in that area. A lot of research is being developed, and a lot of interest, obviously. Our lives depend on it. Now, today we're going to be talking about, we want to go back to work, right? Officials fear the effort may prove as problematic as the earlier launch of diagnostic tests that failed to monitor Americans. Now, what are we talking about? We all want to get back to work, but there are major problems with the antibody test. One of the first comment from today covered that issue. Dr. Brewer, don't you realize that 50% of the tests are wrong? This is the test that he was talking about, the antibody test, the test that is going to be critical to getting people back to work. So, criticized for a tragically slow and rigid oversight of tests months ago, the federal government's now faulted by public health officials and scientists for greenlighting the antibody test too quickly and without adequate scrutiny. So, again, major challenges in that area. It's not delivering yet, and it's creating a major problem for us. There was a good New York Times article. We'll cover that a little bit later. As I mentioned, that antibody test and this problem of half of the folks with a positive test being false positive really depends more on this than anything else. Yes, there are some bad test providers out there, some bad tests, but here's the thing. If you look at this blue line, it's people that don't have the infection, and the red line is people that have had the infection and actually have the antibody. You see, you've got to develop a cut point somewhere in this test. The lower this red point, the fewer people that have infection, the more likely, wherever you draw that cut point, the more likely that you're going to have a lot of false positives. A false positive then is going to lead somebody to think, okay, I'm immune, I can go back to work, I'm not susceptible, I don't need as much, I don't need to worry as much about distancing. So all of that, all of our lives and our economy depend on this issue right now. We're not going to get too much deeper in that today. We're going to be talking about this. Thousands of coronavirus tests are going unused in labs. This is talking about the PCR test, the virus test, the test to see if we have virus in our blood, if we're infectious. As you know, we've gone over this issue many times. It has been, again, also lethal because it's critical for understanding how much spread is going on and where that spread is going on. So, a lot of issues in this space. Now that we're finally getting some of this test up and rolling, here's part of the problem with this. There are a lot of tests that are sitting in hospitals that aren't being ordered. Now, why would that happen? So we're going to go back and dredge up a little bit of the who struck John and what the problems were associated with getting the virus test up and rolling. Before we do, though, just a quick word from our sponsor. And obviously that would be me. At least now I'm our largest sponsor, but I'm not at all our only sponsor. We've been getting a lot of interest with these YouTube Live dailies. And we've been getting a lot of patrons on Patreon. A lot of folks have been using Super Chat. So this word from our sponsor, by the way, is as important. Yeah, it's as important for our patients as it is for us and folks that need to be our patients. It's a question. What is e-prescribing? How does it work? And 61% of prescription errors are due to bad physician handwriting. Now, this may sound like, what's that got to do with anything that we're talking about? Here's the thing. You need to be making sure that whoever you see is using e-prescribing. We use e-prescribing, and here's why. Look at this. 61% of the errors that are made with medications are made because of bad doctor handwriting. I got, as you know, I've spent a career running healthcare systems, and we got e-prescribing up and rolling decades ago in our systems, way before there was the current adoption of telemedicine. So we are providing telemedicine to folks. We obviously use e-prescribing. I'm not going to go into more detail on that, but we're not the only folks providing telemedicine. Just when you get up and rolling, though, and seeing your doc, ask them about e-prescribing. With us, 15 to 30 minute slots, click the button, same day or urgent, you can schedule with Michelle. Maybe Michelle or Clyde or Lori, we can help provide a little bit more information regarding which button we're talking about clicking. One other update on something, and then we'll get to our feature for the day about the virus test. The book. I've had a lot of questions, more and more questions about, okay, when are you coming out with the book, Doc? First of all, here's the title of the book, and it's What a Stress Test Can't Tell You. I've been ranting and raving against using stress tests to predict heart attack. It's because they don't. They miss 2/3 of heart attacks. It's because you got to have 50% or more plaque in the arteries of your heart. But 2/3 of heart attacks occur in people that have less than 50% of their plaque. So that's a problem. Now, there were, what, 15,000 stress tests done every day in the US prior to COVID-19. We talked about COVID-19 silver linings. In my mind, there's been a huge decrease in stress testing, and the vast majority of it was being misused, used to predict heart attack and stroke risk. And to me, that's one of the silver linings. Folks need to understand how to predict their heart attack and stroke risk. It is still, by far, the major killer, not COVID-19. And stress tests are not the way to predict heart attack and stroke. So why isn't it out there? It's at this point, for the past month or so, it's been me. I've been up and totally focused on COVID and trying to mount a response to that. The book starts off very well. It gives a good, engaging story, but then unfortunately I dive, as I often do, into way too geeky mode. It's on cardiovascular inflammation, and I get into biomarkers and cells. We need to back off on that. I need to just put that in a footnote or an appendix. Once I get that done, then we'll get it to the publisher and be able to get it to those of you who have been asking for it. Now, we're getting ready to talk about unused coronavirus tests in the US labs right after Carl gives us an intro. So as I mentioned a few minutes ago, this is about the PCR test, polymerase chain reaction test. This is the test for virus, not the test for antibody that we're talking about. This is basically coverage of an article that was in Nature magazine, one of the top science magazines in the world. So here's the background. The WHO vetted and distributed a German-developed PCR test. Originally, this is over a month, well over a month ago. However, in the US, the CDC developed its own test, and it did not permit use of any other test during the entire month of February. Now, Late February, the CDC tests were found to be faulty and in shortage. So many of you have heard this before. The CDC came under a lot of criticism for this. In the beginning, I defended them. I've defended their activities in this space many times in the past, but this time I think they screwed up, and they as much as admit it themselves. And we'll do a video a little bit later with Robert Redfield talking about this issue. His perspective was, number one, we're not doing this test for the rest of the US world. We're just doing it for public health testing facilities, which is admittedly a little bit of a cop-out. But the next issue, the next reason I, given what I know about the space and the people I've talked to within the space, I do think is accurate. His point was, we've been underfunded for this critical issue. And I think he's right. Again, given what I do, I interact with people in this space and have been for the past few years. We've all been looking for the upcoming pandemic. We've all been warning about it happening. And the governmental response has been to gut the CDC vaccine preparedness or pandemic preparedness programs. And it is what it is. It's not a complaint. It just is what it is. The FDA, after finding out that the CDC tests were faulty and in shortage, began to allow academic labs to do testing. However, the labs need to have a CLIA certificate and before they can do this. And getting a CLIA certificate is a cumbersome process. The CLIA lab improvement amendments came in, 20 years ago? And they did make a huge difference and improvement in lab processes in this country. You had Labs Are Us. Every doctor's office and other places were setting up labs, doing these labs for patients, selling them to them, and misrepresenting the patient's condition. This is a picture of that, of the cover page on that article. Thousands of coronaviruses are going unused in US labs. So how did the labs address this cumbersome CLIA process? First of all, and most conveniently, most rapidly, they would just go ahead and partner with a nearby CLIA certified clinic. So they would, in effect, be using someone else's CLIA certification. Now, they continued to look for more reliable tests. Many decided not to use the CDC's test kit. Again, for reasons that we discussed. Late February, it was found to be a significant problem. Now, the WHO, you say, the next question is, well, why didn't we go back to the WHO test kit? Well, that German-developed WHO test kit had major issues in terms of supplies for the test kit. So one of the common solutions was to partner with private firms and to develop their own diagnostic tests. Now, new barriers are being faced by testing labs: regulatory, logistic, administrative obstacles, again, in our fragmented US healthcare system. Let me give you an example. Several of the large testing groups have said, look, we've got a test that's now available, and it's a good test. We've proven it. And yet they go to large hospital systems, and the hospital system says, look, we're set up with our own labs, our lab contract, and it may even be a national lab. But the problem is we cannot do lab testing en masse with another group because of the ability or inability to transfer data. So again, that's an example of the fragmented US healthcare system. Here's an example. The Broad Institute testing protocols were tweaked to do more coronavirus PCR testing. The capacity was 2,000 tests per day. They only did about 1,000. Supply shortages, hospital wasn't sending samples. The hospital stuck with their diagnostic companies that they were accustomed to, even with longer turnaround times. So Some urgent things needed to be done. We needed to organize the U.S. Testing, need to reduce bureaucratic and logistical information management barriers, and share tips to speed up testing. Now I'm going to go ahead and provide a quick clip, and hopefully the clip will work this time with sound. Thank you again for your patience, those of you who dealt with our tech issue of not having sound last time. So Joe, maybe some of you guys can let us know if the sound doesn't work.
In the state of Washington, if we don't somehow slow down this epidemic, and the next week it'd be 120,000, and the next week it'd be 250,000.
Today, the director of the CDC testifying before Congress, fielding questions about the delay in getting test kits to health providers around the country.
The CDC's focus was to provide testing for the public health system. There's a whole nother system we need testing for, clinical medicine. And I'm happy to say now, with LabCorp and Quest both operational as of yesterday, there's really laboratory testing availability to any doctor's office that can go through LabCorp and Quest. I would have loved the private sector to be fully engaged a few weeks ago.
The CDC plans to aggregate all testing data collected by LabCorp, Quest Diagnostics, and public health labs with the goal of tracking how many Americans have been tested and what those test results are.
Like CDC, the state and local and territory health departments are underfunded. And I want to rebuild the core capabilities so that we have data and data monitorization. Wouldn't it be nice if we had a data system that every health department in this country right now could see in real time so that we could predict what's going on and where to go and where to put assets? We don't have that. Most people.
So you can say that was a cop-out, you can say whatever you want, but it's reality. Our public health systems, especially the pandemic preparedness sections, have been grossly underfunded. And it's not a surprise. Look at the other things that we've done in terms of pandemic preparedness. Personal protective equipment, masks, shields, gowns, gloves. We've been totally unprepared. So thank you for your interest in the program section. I'm going to cut that part out, and then we'll go to the screen, the comments. Thank you, Dr. Brewer. Correct triage is always the key to both personal and community health. Oh, gosh, we skipped way over a lot of them. Hold on just a second. Greetings from Dennis Williams. Good morning. I don't understand from day one. I'm having a little technical challenge here. From day one, why hasn't the president marshaled Google? Verily, I'm not sure what you mean by that. Actually, you bring up a good point, though. Google's got a very interesting system, and we're going to be covering that in a week or two. It has to do with how they're tracking. You're able to track people. They're allowing volunteers. They're not tracking people that say, I don't want to be tracked. And they're giving information on just how well are we actually distancing. And I think you can guess the answer. Not so good. $23andMe is setting up for massive testing. We're on our way to the Capitol in Harrisburg, Pennsylvania now. Interesting. Wonder what you're going to be doing. Good morning, Teb. Florida. Good morning, Joe. Thank you. I find listening to the Q&A to be of value. Just clearly delineate when lecture part is over and the beginning and Q&A. Well, thanks, James. I'm not good at clearly delineating anything. I know that's one of my major challenges in terms of public speaking. But one thing we try to do, if we've got the technology working, is actually show the question when we're doing Q&A. So again, I thought I gave a little bit of a transition a minute ago in terms of saying, we're done with the program piece, we're doing Q&A. Jan H, 43,000 dead from COVID-19 and no deaths from regular flu reported by the CDC. We are midway into U.S. flu season, wherein the CDC had estimated this time 40,000 deaths from regular flu. What's up? It's a really good question. Actually, it brings up another point, and that is how many people would have had heart attack and stroke during this time period, and that's being reported as COVID-19. We're going to start covering our estimates on that issue. And here's part of the thing. I don't know that I would assume that all of that's incorrect. COVID-19, for example, not SARS-CoV-2, which is the virus, COVID-19, which is the more lethal type of serious infection from that virus. That's getting a lot of people that would have been having heart attacks and strokes anyway. Those are the folks that are most susceptible to this. So a lot of times we're going to see decrease in heart attack and stroke and increase in COVID-19. I think there may be some of the same going on with flu. Not that they didn't get flu, but again, if you've got a highly infectious process coming in, some of those people would have gotten sick from other reasons. Good Garden of Peace. CDC, in its latest report, estimated that there have been at least 23,000 deaths related to the flu as of March 14. Dennis Williams, thank you, Doc. Correct triage is always the key to both personal and community health. I agree with James Cantor. The Q&A is valuable. I enjoy when I'm not able to join live daily seminar. Thank you very much. I appreciate that. David Drake, for those who have panic over antibody tests and false positives, nothing new. Google false positive AIDS test. This is an old test and well studied, but false tests still exist. Joe says, I think things went well. So we're going to be trying to shorten these things so we don't have a full hour. If anybody has anything else that they want to ask, go ahead and let me know. But other than that, we will be signing out. Thank you, Carl.